Hello, my name is Nancy Benavides, and I'm a current PGY2 ambulatory care pharmacy resident at Kaiser Permanente, Colorado. Today we will be discussing the D-PRESCRIBE trial, the effect of a pharmacist-led educational intervention on inappropriate medication prescriptions in older adults. This trial was published in JAMA in November of 2018. At this time, I do not have any conflicts of interest to disclose. Throughout this presentation, we will be discussing a few of the definitions on this slide, and I want to make sure everyone is familiar with how the study defined these. Usually, when we think of deprescribing, we think of a complete discontinuation of a medication. However, sometimes reducing the dose of a necessary medication is completely appropriate and beneficial for the patient. For the purpose of the D-PRESCRIBE trial, we will only be looking at a complete cessation of any unnecessary medication. Inappropriate medications were defined as any medication that can cause a risk of harm where a safer alternative is available. It is important to note that the D-PRESCRIBE trial was conducted in Canada. In this country, a pharmaceutical opinion is a legal and reimbursable document that eases communication between a pharmacist and a physician. The pharmaceutical opinions used in the study were created by the research group and were evidence-based and standardized in order to communicate a clear rationale for why deprescribing was being recommended, to show clear evidence of potential drug side effects, and to provide a safer taper for specific medications or a therapeutic alternative to the inappropriate medication. I will show an example of what one of these looks like in a later slide. As pharmacists, we are aware of the issues that can arise from inappropriate medication use in elderly adults. These can range from adverse drug events, falls, cognitive impairment, and unnecessary hospitalizations. In 1991, the first Beers criteria was published. This list included medications that were considered not appropriate in older adults, and its intention was to improve care for older patients while avoiding adverse drug reactions. This list is now in its 6th version, and it continues to be used by healthcare providers around the world. Looking at Medicare data, in 2015, 29% of beneficiaries were filling at least one medication that was on the 2015 American Geriatric Society Beers criteria. In comparison, about 31% of older adults in Canada were also filling at least one medication on this list. Even though our healthcare system may look much different than Canada's, these numbers are very similar and tells us that there's an ongoing problem that could be due to a variety of reasons. One of these reasons may be perceived barriers of deprescribing from primary care providers. A systematic review by Anderson and colleagues showed several perceived barriers, including poor awareness of harms and medications from prescribers. This could be mitigated by interventions to raise awareness. However, even if the prescriber had increased awareness of the harms of the medication, fear of what would happen after discontinuation, such as withdrawal symptoms, could create inertia around deprescribing. Extrinsic factors also came into play and included a lack of time and resources, as well as patient criticism and difficulty getting the patient to accept an alternative medication. Both of these factors can be eased through support from pharmacists through education of both the prescriber or the patient, as we have seen in studies in the past. One of these studies is Monan and colleagues, in which direct outreach from a pharmacist to a prescriber was attempted. Pharmacists were only able to reach physicians about 56% of the time, which goes back to PCP's perceived lack of time and resources. However, when the prescriber was reached, 15% agreed to switch to a safer therapeutic alternative, and 9% agreed to switch at a later time. A second study by Tenenbaum and colleagues called Empower looked at communication between a pharmacist and patient through educational materials meant to enable patients to discuss their concerns with their prescriber. This intervention resulted in a 30% discontinuation rate of benzodiazepines. Despite both of these studies, there is little known about the synergy of implementing more than one intervention that can target both the patient and the physician. The D-PRESCRIBE trial does just this. The pharmacist initiates and influences the de-prescribing process by simultaneously conveying information to both the physician and the patient prior to the doctor-patient encounter, and thus alleviating any concerns for any of the barriers of de-prescribing from primary care providers. The D-PRESCRIBE study objective was to compare the effectiveness of a pharmacist-led intervention to educate older adults and their physicians about reducing inappropriate prescriptions versus usual care on discontinuation of inappropriate medications. This was a community-led effort that consisted of two-group, parallel, pragmatic, cluster randomized trial of 69 community pharmacies. What this means is that each of the 69 pharmacies had both the intervention and control group. The study was conducted in Canada from February of 2014 through September of 2017, and it had a 6-month follow-up. A total of 489 patients were included. Patients that were eligible for enrollment consisted of older adults or ages 65 and older that were prescribed one of 4 targeted Beers criteria medications, which we will go over on the next slide. Patients had to be on one of the 4 medications for at least 3 consecutive months. If patients were on more than one of the targeted medications, they only received one intervention based on the first medication that appeared on the list. The 4 Beers criteria medication classes that were chosen were sedative hypnotics, and these included benzodiazepines, zolpidem, and zopiclone, which is only available in Canada. First-generation antihistamines, glyburide, which is a long-acting sulfonylurea, and selective NSAIDs. The authors of the study did not specify what first-generation antihistamines or NSAIDs were included. Interestingly, the protocol initially included anticholinergics such as amitriptyline. However, these were not included in the trial. In order for pharmacies to be eligible, they had to have a clientele of at least 20% older adults. Pharmacies were sent a list of eligible patients that were randomized and separated by each of the 4 Beers criteria medications that were included. From this list, a minimum of 3 patients from each medication class were recruited, or until all of the patients on the list were contacted. Patients that had a diagnosis of severe mental illness or dementia based on prescriptions for memantine, antipsychotics, or cholinesterase inhibitors, or had a score of less than 24 on MMSE were excluded from the study, as they did not have the capacity to provide informed consent. Lastly, if patients lived in an assisted living facility, they were also excluded, as they were more likely to be monitored for adverse events and potential discontinuation of medications. Within each of the 69 eligible pharmacies, patients were assigned on a 1-to-1 ratio to either the intervention or control group. Blinding was done at both the individual and pharmacy level. Masking was not possible due to the educational nature of the study. However, pharmacists and patients were blinded to group allocation by being told the study was a medication safety study for older adults and that the intervention would be delivered in the next year. For the intervention group, pharmacists provided drug-specific educational materials to patients and a pharmaceutical opinion to physicians. These materials included information about why a medication may be inappropriate and also potential safer therapeutic alternatives. These materials were distributed either in person or by mail. Specifically for patients on benzodiazepines or hypnotics, a taper protocol was included in the pharmaceutical opinion. The control group consisted of pharmacists providing usual care without educational materials or pharmaceutical opinion. Here's an example of what the provided pharmaceutical opinion prototype looked like, specifically for the sedative hypnotic drugs. As you can see, suggested alternatives not only include a therapeutic alternative, but include non-pharmacologic alternatives as well as safe tapering schedule. The primary outcome of this trial was the complete cessation of prescription fills for any of the 4 medication classes 6 months after randomization and sustained for at least 3 months, without the addition of another inappropriate drug. Secondary outcomes included evaluation of the process involving the pharmacist providing educational materials to both patients and providing educational materials to patients and pharmaceutical opinions to physicians, and only consisted of patients that completed a 6-month follow-up. These included, but were not limited to, assessment of the delivery of educational brochures to patients, prevalence, timing, and type of pharmaceutical opinions sent to PCPs, effect of pharmaceutical opinion on prescribing physicians' behavior, participant-physician encounters to discuss inappropriate prescriptions. The primary outcome was assessed through risk differences that were estimated using generalized estimating equations of those exposed to the intervention versus those that were not exposed. Both intention to treat and per-protocol analysis were performed, and both subgroup and interaction analysis for each specific medication class was conducted. About 66% of the patients in the study were women, and the average age of patients in the study was about 75 years of age. Baseline characteristics were similar between groups. About 1/5 of the patients had a self-reported health of fair or poor, and slightly over 1/3 of patients were taking greater than 10 total medications per day. The majority of patients were taking sedative hypnotics and glyburide. It is important to note that first-generation antihistamines and NSAIDs can be purchased over the counter, and therefore not all of their use may have been captured. Given the average patient age in the study was 75 years, and the percent of patients that were on these medications for greater than 5 years, leads us to believe that these were not new medications. As many of us have experienced, it is much more difficult to stop a medication than it is to start one. Of note, the sample size for first-generation antihistamines was too small for subgroup analysis. The primary outcome showed that after 6 months, 43% of the patients in the intervention group had stopped at least one inappropriate medication, compared to 12% in the usual care group, and this was statistically significant. For subgroup analysis, we can see the results for each of the targeted groups of medications with the exception of first-generation antihistamines. After 6 months, 43% of the patients in the intervention group had stopped using a sedative or hypnotic, compared to 9% in the usual care group. About 31% had stopped glyburide versus 14% in the usual care group, and about 58% in the intervention group versus 22% in the usual care group had stopped using NSAIDs. Secondary outcomes involved evaluation of the process of delivering educational materials to patients and pharmaceutical opinions to physicians. Of the 270 patients in the intervention group, all received educational materials, and 79% of these patients had a discussion with their physician about D-PRESCRIBing. 219 patients completed a 6-month follow-up. Of these, 66% had pharmaceutical opinions sent to their physicians. Discontinuation rates were higher in patients whose provider had received a pharmaceutical opinion versus those who did not receive one, as you can see in the 2 boxes at the bottom in red. Reasons that pharmacists provided for not sending pharmaceutical opinions included patient request, patient had stopped medication on their own, or the patient had previously discussed with their physician. Of those who were discontinued on the targeted inappropriate medications, 37 individuals had substitutions. One person was switched from a first-generation to a second-generation antihistamine. 12 people were switched from glyburide to glycoside, a sulfonylurea that is only available in Canada, and it has a similar half-life to glyburide. Another 6 people in the glyburide group were switched to sitagliptin, and 6 others were switched to saxagliptin. The conversions to DPP-4 inhibitors may have been more appropriate given their lower risk for hypoglycemia. 7 patients in the NSAID group were switched to either acetaminophen, tramadol, or low doses of pregabalin. And in the sedative group, 2 patients were switched to zopiclone, 1 was switched to lorazepam, 1 was switched to oxazepam, and 1 was switched to diazepam. And all of these were considered failed for deprescribing attempts. The authors concluded that a pharmacist-led educational intervention resulted in greater discontinuation of inappropriate prescriptions compared with usual care after 6 months, and efforts that directly involve patients and the decision-making process to deprescribe are more effective than a pharmacist's communication to physicians or software alerts alone. I agree with these conclusions. Educating patients and empowering them to become self-advocates alleviates prescriber-perceived patient resistance to stopping medications. Hand in hand, by assisting providers with awareness of increased risks for adverse effects and providing them with the tools to make therapeutic and non-pharmacologic alternative options, we as pharmacists are having a greater impact on these patients. Some of the strengths of this study included its study design. As a cluster randomized trial, real-world effectiveness was evaluated. The educational materials and pharmaceutical opinions also gave specific insight to patients and could be individualized to specific patients if needed. The study question was current, appropriate, and comprehensive. Previous studies have been completed evaluating each intervention separately. However, this study evaluated both interventions synergistically. In order to meet power, at least 17 pharmacies needed to be recruited per group, and this was met with over 30 pharmacies in each group. In addition, 51 patients per group per drug class needed to be recruited. However, only the sedative hypnotic group and the glyburide group met this requirement. This leads us into some of the limitations of the study. Unfortunately, there were difficulties with recruitment of patients using first-generation antihistamines and NSAIDs. Both of these medications are available over the counter and may have been difficult to capture their use through claims data. There are other medications in the Beers criteria that may have been appropriate to use, such as anticholinergics like TCAs or opioids. Even though about a third of pharmacists opted out of sending the pharmaceutical opinion to physicians, they still had access to these, and it may have influenced their conversations that were had with the patient. The only adverse events collected were those requiring hospitalizations or those experienced due to sedative hypnotic withdrawal. A longer follow-up may have increased the number of discontinuations or the number of patients restarting medications. Although the study's primary outcome was rates of discontinuation, it may have been interesting to see if patients with dementia that had a sedative hypnotic stopped could have contributed to resolution of symptoms. This study is important because it evaluated 2 interventions synergistically. We have known that interventions such as pharmacist consults for deprescribing are effective. However, they are still difficult to implement in the real world because of time and resources. By involving the patient directly in the decision-making process, we as pharmacists are giving them the tools to be able to have a discussion with their physician and breaking down any additional extrinsic barriers that may be impeding deprescribing of inappropriate medications. More data may be needed to determine clinical outcomes of adverse effects that were prevented from deprescribing. Although the article stated that they looked at hospitalizations, these were not reported. This study showed that pharmacists' roles in community pharmacies can have a big effect in deprescribing. However, the interventions from the study can also be used in other ambulatory care settings, such as primary care clinics, and this can continue to influence de-prescribing. In these settings, pharmacists usually have more face-to-face interactions with both physicians and patients, and therefore interventions such as a pharmaceutical opinion and patient educational materials can be easier to distribute and can also be more meaningful when discussing in order to continue to have impactful outcomes. The key takeaways from the study is that pharmacists can provide both patients and prescribers with tools to ease the de-prescribing inertia, and it can be much more effective at optimizing patients' therapeutic plans. I would like to thank my mentors for their support and efforts through the creation of this ACCP Ambulatory Care PRN Journal Club. Thank you for joining me today, and please feel free to contact me with any questions that you may have.